course of the rotation, you'll see some of those specialty treatments that we do, particularly as Everett mentioned, with stereotactic body radiotherapy, which is kind of a more advanced technique that radiation has, developed to be able to basically mimic, surgical outcomes. So for instance, we can now, basically ablate lung tumors with radiation, and potentially, prevent the need of a surgical resection. For a lot of patients who have lung cancer, they're not in best of shape to be able to have a surgery, and radiation has actually become a standard of care to basically treat lung tumors, as we call it radiosurgery. It's been used like that for things in the brain. I do that specifically for things, tumors in the liver, tumors in the pancreas, tumors in other various abdominal organ sites. And so that's kind of one of my areas of specialty. What we're going to focus on today, and so first off, I think you can use the chat to ask any questions, and Everett will help moderate that. But I mean, I do kind of miss the engagement of actual hearing people's voices. So if anybody actually wants to like say a live question, I think we still remember how to respond to live questions. So if you want to do any of that, feel free to just chime in. If you want to interrupt or save them for the end, please feel free. So this lecture is really just GI malignancies, anatomy, and overview, and it has my name on it, but I've got to give credit where credit due. These slides are pretty much borrowed from one of our former residents who gave a really nice anatomy overview to our residents a couple of years ago, Nick Prionis, who's now at UCSF. So Nick, if you're out there listening, or if you come across this recording, thank you very much. You're a lifesaver. It's kind of for me, it's a little bit interesting, and it's easy, but it's difficult talk because most of the lectures we give are going to be very deep dive into literature and the data for each of the different disease sites. And GI, what makes it challenging, but also I think very exciting and interesting, is that it's really, multiple sites all crammed into one, right? Because the GI tract extends pretty much from the bottom of your pharynx, where your esophagus begins, all the way down through to the very other end, which is the anus. And every disease site has its own body of literature, its own treatment algorithm. You have different surgeons dedicated to each type of organ. So it offers a lot of variety. It offers a lot of challenges because you have to really stay up to date on, the latest literature that's going on in each site. They all have their own controversies. And so, that's usually what we do is we spend, an entire day or entire session on just deep diving into each of these subsites. What we'll attempt to do today is just kind of overview what the current treatment status is with the different GI sites, and really most importantly, kind of how radiation fits into it, because I understand you probably don't see or hear too much about this when you're doing your clerkships, you're doing your surgery rotation, your internal medicine rotations. You may not have had much chance to interact and see where radiation oncology and radiation therapy fits. So hopefully we'll try to give you some of that exposure. With this, really just gives you kind of the anatomic breakdown for the sites of GI cancers. We're going to try to go through basics of anatomy, epidemiology, risk factors, how we work them up, staging and how it may impact our treatment decisions, and then what the overall treatment paradigm is. And then for the different sites, like I said, starting from the esophagus, stomach, pancreas, hepatobiliary, so hepatocellular carcinomas, which are primary liver cancers, cholangiocarcinomas, which can be both intrahepatic and extrahepatic cholangio, as well as gallbladder, rectal cancer, and anal cancer. So starting with esophageal cancer, this is my slide, but this just kind of gives you a breakdown of the anatomy of the esophagus. It's broken up into the cervical esophagus, which is the part of the esophagus that extends outside of the thorax, basically from your larynx, from the bottom of the cricoid down to basically the thoracic inlet. So it's about a 5 centimeter or less structure. And then you have your thoracic esophagus, which extends from your thoracic inlet all the way down into the abdomen, where it pierces the diaphragm, and that's your thoracic esophagus. And then some people there's an abdominal esophagus, which is this very bottom portion, which others might call the gastroesophageal junction. But that's essentially what we're talking about here. And the way we measure the location of tumors, whenever you see these reports on EGDs or EUS reports, is we usually measure it from the incisors. So you stick the scope down a patient's throat, and the scope has these markings, these centimeter markings. And what they do is they take the scope and take it all the way to where the tumor begins, and then they'll read what marking they are on from measuring from the patient's incisors, their teeth, the front teeth, and that's how they measure the distance. And so we usually say that the cervical esophagus begins at about 15 centimeters from the incisors, and the thoracic esophagus begins at 20 centimeters. And then the entire length, it usually ends around 40 centimeters. Incidence, it's a relatively rare cancer, but it is very deadly. 18,000 per year in the US, but 15,000 deaths. So whenever your death rate and your incidence rate approximate each other, the closer they are, it gives you a sense of how deadly it is. These risk factors may or may not sound familiar to you from your, preclinical and some of your clinical years, but smoking, alcohol, not a surprise, Plummer-Vinson syndrome, ingestion of certain caustic agents, lye ingestion, other types of, having a concurrent head and neck cancer actually gives you increased risk. And HPV is probably a little controversial. I think there's some reports that HPV, which is definitely responsible for oral pharyngeal cancers, may play a role in some of these upper esophageal cancers, but it's not a commonly mentioned thing. But these cancers tend to occur in the upper part of your esophagus, so closer to the, to the upper airway. But then as you get closer to the when you get closer to the stomach, you tend to get a different type of histology called adenocarcinoma. And these are actually more related, some may call it a different disease altogether. It tends to be more related to things like obesity, gastroesophageal reflux disease. Barrett's esophagus is from chronic reflux. They have different patterns of failure. Squamous cell carcinomas tend to recur more local regionally, and they tend to be more radiosensitive actually, compared to adenocarcinomas, which tend to actually fail more distantly. They tend to spread more distantly. And so that has implications on different treatment options for them. Common presentation would be a patient with, dysphagia, trouble swallowing liquids, perhaps some weight loss. And if you look at them, you could probably tell there are certain stereotypical patients that you can think about. For patients with squamous cell carcinomas, the most common risk factor would be things like smoking and drinking. These patients may have, emphysema. They tend to be thinner, more cachectic looking. They tend to be older. Patients who have GERD tend to be a bit more obese. And they tend to be a bit younger in age, actually, kind of in their middle age, 50s, 60s timeframe, or age period. Workup, H&P, labs, but the main procedures that you do, you get an EGD, so you take a stethoscope directly down, do a biopsy. We do endoscopic ultrasound, which is what you do to stage a tumor. So you want to know the T stage, which is a measure of how thick the tumor extends through the wall of the esophagus. And the gold standard for preoperative staging would be an endoscopic ultrasound, where this here's a picture of what that looks like. Basically, the probe is this center part, and then you can visualize the different rings, the concentric rings, which are the different layers, the mucosa and the muscularis, et cetera. And you can measure how thick the tumor goes through, and if it pierces through the esophagus, the esophageal wall, it's considered a T3. You might consider getting a bronchoscopy if you have an upper tumor, and then you get CT scan imaging as well as PET scan. The PET scans are very useful for looking for distant metastases. These tumors tend to be very bright on a PET scan, so they tend to light up. So you can see here's a primary tumor, and oftentimes we do pick up lymph nodes that you otherwise would not have seen on a CAT scan. And then this just kind of goes through sort of the different stages. T1 would be essentially confined to the mucosa or submucosa. T2 is into the muscularis but not past. T3 is past submucosa, and then T4 is invading into a nearby structure. And these are generally common themes for most of the GI cancers. And then they have different nodal staging, based on the number. And then metastases would be anything that is considered a distant metastasis. And then here's the different treatment paradigms. And you can see where radiation fits. So if you have a cervical esophageal cancer, I mean, people do cervical esophagectomies. I don't know if you've seen any of them in your medical school. I trained at a place where I remember that was actually done, but I would say that most places probably would treat them with definitive chemoradiation, just because it's a very morbid procedure to do a cervical esophagectomy. Sometimes it could lead to like a laryngectomy, for instance, so a patient may lose their voice box. So chemoradiation is considered a standard of care. We tend to treat these like head and neck cancers, so you use cisplatin 5-FU with about 6 to 7 weeks of radiotherapy. If you have a thoracic esophageal cancer, if you're very early stage, usually an esophagectomy alone would be enough. But if you have anything that's considered locally advanced, so locally advanced is considered T3 to T4, or having any node positive disease, the standard of care right now, based on a very important landmark trial, is preoperative chemoradiation for about 4.5 to 5 weeks with chemotherapy, which is carboplatin Taxol, followed then by surgery, okay? And then if you're not operable, then chemoradiation would be considered the standard of care. There are some nuances to this, just as I mentioned before, that there's some people think if you have a squamous cell carcinoma, they tend to be more radiosensitive, so you could potentially treat them with chemoradiation alone. And there is some data to support that, but most people would still stick to surgery. If you can do preoperative chemoradiotherapy and then surgery, that would be the standard of care. That's my preference. But the reason why I say that is if you look at the cross trial and you look at the data from that trial, this is a trial that randomized patients to just surgery alone or preoperative chemoradiation followed by surgery. If you look at the patients who had preoperative chemoradiation and then surgery, they actually looked at the pathologic specimens and they looked to see who had a complete pathologic response, meaning when they looked under the microscope, there was no evidence of any viable cancer cells. And that would obviously be a very, very good result that you want to have in your patients. Less than a quarter of patients who had adenocarcinoma had a pathologic complete response, whereas nearly 50% of patients with squamous cell carcinomas had a pathologic complete response. So, this may open the door for the possibility of not doing a surgery, but I'd say that's still something that is probably done in the minority of the time. So moving to gastric cancer, this is your stomach. It is the terminal end where your esophagus enters and becomes your stomach. This region here is called the GE junction, the gastroesophageal junction. And there is some controversy about how patients who have GE junction cancer should be managed. Should they be managed like a stomach cancer, or should they be managed by an esophageal cancer? Most of us here at Stanford, at least in many other places, would default to treating them as an esophageal cancer. So like what I said before, preoperative chemoradiation followed by surgery. Gastric cancer is treated a little bit differently. Generally, it's treated as a surgical disease up front. Just know it's divided into different parts. You have the proximal or cardia region, you have the mid or body region, then you have the gastric antrum or the distal stomach. I'm not going to get too much into lymph nodes, but this is probably it's an important surgical and radiation topic about taking an adequate number of lymph nodes when you do a surgery. So that's kind of a common theme with a lot of these disease sites is whenever you do a surgery, you obviously want to know how many lymph nodes were involved with cancer, but the other important number to know is what was in your denominator. You want to make sure you had an adequate sample of lymph nodes to make sure that you have that you can accurately stage them. And then, there's a magic number in there somewhere, and a lot of people have tried to publish on what that magic number is. And most of it seems to settle in around somewhere between getting 13 to 15 lymph nodes out of your surgical specimen as considered to be an adequate lymph node dissection. Gastric cancer it's definitely, a significant entity here in the US, but it's much more so in other parts of the world, particularly places like Asia, Japan. It's probably considered one of the most common cancers there. So they have a lot more literature and a lot more experience in treating gastric cancers, but we do definitely see it in the US. Various risk factors include H. pylori, certain types of smoked or salted foods, smoking, obesity, also GERD. Pathology, there's really histology, two different types that we think about. Intestinal, which is thought to be a bit more of a well-differentiated carcinoma. They tend to form more glands, whereas you have a diffuse type, which is less differentiated. Signet ring cells has been sort of described as part of it. It tends to be a bit more diffuse and submucosally spreading, and these tend to also metastasize more. And so this diffuse, you can imagine, is a more dangerous histology to have compared to intestinal. Presentation, the symptoms are not too surprising, but things like abdominal pain or discomfort, early satiety is a common one, anorexia, trouble eating, weight loss, fatigue, etc. You could have bleeding, so you might have hematemesis, or you might have melena. The workup is interesting. It's a bit evolving because the treatment is changing. I would say, up front, the surgery has been kind of the mainstay of treatment. And what surgery also does for you is it actually helps you to stage the tumor. So it's primarily a surgically staged disease. So you basically look at it under the microscope to tell you how deep the tumor invades. But there is a big push to doing treatments more with preoperative chemotherapy. And so if you do preoperative chemotherapy, then you obviously lose the ability to stage because you've now offered treatment. So we have to then use sort of preoperative staging tests, things like EGDs, EUSs, possibly diagnostic laparoscopies to look for peritoneal carcinomatosis, which actually can be fairly common for gastric cancer, as well as contrast imaging, which usually involves CT scan with a PET scan. I'm not going to say too much more about that, just because I think there's a little bit of variation in how things are done, but you try to get a sense of how locally advanced a tumor is. And then here's the staging. It's slightly different from esophageal cancer, but both in the T stage and N stage, but it just gives you a sense of the deeper it is, the more locally advanced it is, and the more nodes you have, the worse. So here, walk you through kind of how this all works. I would say that, a couple of years ago, radiation had a larger role in treatment of gastric cancer, but there's been recent publications of trials coming out that have kind of shown that radiation essentially doesn't really have much of a role anymore for gastric cancer. So this slide used to have a role here for radiation, which we'll get to, but I'll talk about that in a second. But for early stage disease, if it's very early, very small, confined in the mucosa, you could probably hopefully get away with an endoscopic mucosal resection. So you actually can just remove the tumor through an endoscope and not actually have to cut a patient open and do a big surgery. But for other tumors, more locally advanced tumors, the old school method was to basically do a surgery with a lymph node dissection. And then you would follow that up with either post-operative chemoradiation. You might do post-operative chemotherapy. This is more of an Asian treatment method. Or you could do what's called perioperative chemotherapy, which means you give chemotherapy before and after surgery. And that's been actually established by a number of really important randomized trials showing that this actually improves survival over surgery alone. So you actually may do perioperative chemo and not go straight to surgery, but do chemo followed then by surgery and then more chemo. And I would say nowadays, probably I'll take away the radiation arm because enough studies have looked at the role of post-operative radiation, and there really hasn't been shown to be any superiority by adding radiation to the picture. So we are pretty much left with kind of these two different paradigms now. And radiation plays a very, very small role. I'd say, once a year I might see a patient where they may not be ideal candidates for this. And so sometimes we bring radiation to the picture, but this is probably the standard of care. Pancreas cancer, which is one of my particular areas of specialty. This gets a lot of press, a lot of notoriety because it's a very deadly cancer. One of the deadliest cancers that we come across in the entire body. And, you may have seen or, helped assist in Whipples and things like that. And those are the common surgeries that are done for treating these types of cancers. The pancreas is this long organ that aids in digestion as well as with hormone function for digestion and diabetes or sugar control and other things. But it sits kind of tucked away, and what makes it challenging is because of where it sits. It sits right in the middle of your abdomen, and as you see it nestled between a lot of really important things that go through it. It's this long organ that goes all the way from the splenic tail all the way across, and it snuggles up right against the duodenum, the stomach. You can see that the bile drains right through it, and everything empties into the duodenum. And what's more important is the fact that it's very close to some very, very important blood vessels that you should hopefully remember from anatomy, which is your celiac trunk and then your SMA, your superior mesenteric artery. And so tumors often arise in the head of the pancreas, which is this kind of proximal third of the pancreas. This midsection here is called the body, and then over here would be the tail. And about 90% of tumors arise in the head, which is problematic. It's a mixed blessing in some ways. So it's very problematic because very often it's going to get entangled with the blood vessels, which then potentially can make the tumor unresectable. But the positive side of it is that if you have a very small tumor that happens to just, encroach on your common bile duct, it would then cause a patient to be obstructed. They would turn yellow from jaundice because of the bile. And then that often can be a very early sign that a patient has pancreas cancer, because otherwise, you know, to diagnose pancreas cancer without that, it can actually be quite challenging. So tumors that often arise over here in the body or the tail, when you don't have that early sign of obstruction, they could go months with just, vague abdominal pain, cramping, weight loss. No one really knows why. And eventually someone will get a CAT scan, but by the time they get the CAT scan, the tumor could be very locally advanced at that point. So, there's a number of reasons why this is a very challenging tumor to treat. I just updated this literally like 10 minutes ago because these were older stats. But, when I started 13 years ago here at Stanford and I was doing my talks for pancreas cancer, the numbers were probably like less than 40,000 at that time. And it was still like the 9th or 10th most common cancer. But it had about maybe like a 38 or 40,000 incidents per year in the US, with a death rate that was probably around like 36,000, something like that. So still very deadly. But very sobering is that over the last 13 years, these are 2020 statistics. It is still the 9th most common cancer, but the numbers like probably gone up almost 80%. It's now almost 60,000 per year. But what's quite interesting, it used to be the 4th deadliest cancer, but I was adding up the numbers, and if you add it up, the total number of deaths is 47,000 a year, which now makes the 3rd deadliest cancer behind lung and behind colorectal. And I'll tell you, colorectal is only at 53,000 per year, which is good for colorectal, but it means that for pancreas cancer, just a few more thousand, it has to go up, and it's actually going to become the 2nd deadliest cancer in the US. So it's actually quite scary. Risk factors, there's things out there. Smoking is mentioned as one. I remember learning depression being associated with pancreas cancer as well, and there's some chemicals, but and there's some familial syndromes and genetic component to it, but there isn't some like clear classic risk factor that we can think of for being diagnosed with pancreas cancer. What makes it so deadly is that while it is a local regional problem, the biggest component by far of spread is going to be distant. And once it becomes distant, of course, these patients, are considered incurable. So we mentioned that the most common presenting symptoms would be things like painless jaundice, although pain actually comes quite often at presentation. So the painless part is a bit of a misconception. Weight loss, as I mentioned, and then there is a very clear association of diabetes, development of new onset diabetes within about a year of being diagnosed with pancreas cancer. I'm still not sure exactly what they do with that information, because we know it's there. The question is do people with new onset diabetes, when they're older, do they get any kind of special screening for pancreas cancer? And I'm not aware that they are, but it would be certainly something to think about. The workup is very standard as far as H&P and labs. You would get a CA19-9, which is an important tumor marker, but this could be falsely elevated if a patient's jaundiced. The most important procedures are, of course, if a patient has jaundice, you might want to think about unblocking them. But the first thing you'd probably do is getting a CAT scan to see what's going on, because they certainly could have blockage because of, a gallstone or something that's benign, hopefully, or, they could have pancreatitis for all you know. Usually, though, if you do see a mass in the head of the pancreas, that's where obviously then you need to you obviously have to call in your surgeon, and you have to figure out really probably the most important question for your patient, which is the tumor resectable, right? And that's how you would base that on the relationship of the tumor with the neighboring blood vessels, primarily the SMA, which is this is the superior mesenteric artery, as well as the celiac trunk. And I think I have a slide about those definitions. And then the other important thing is eventually, if the patient is not resectable or they can't go to surgery, you would probably, you would need to relieve them of their obstruction. So you do an ERCP, place a stent so you can open up and get the bile to flow. EUS, most commonly for a biopsy if you need tissue. And then staging, so.
Dr. Chang?
Yeah.
Can I ask you a question about CA19-9?
Sure.
So I've had multiple patients on medicine service where we order this in CA when we're thinking about possible malignancy. And every time, regardless of what it comes back as, I feel like we disregard it and we just, go based on what the RCP or USFNA shows, do these biomarkers actually affect like kind of like the diagnostic determination or initial management?
I mean, yes and no. So there's a number of issues with CA19-9, I think, that need to be taken into account. So if a patient comes in jaundice, they're going to have an elevated CA19-9 just from the jaundice alone. So any kind of mild elevation, you have to kind of take that into account. So it doesn't necessarily mean it's cancer. I mean, the most important indication for you that a patient has cancer is you're going to see a mass in the pancreas. And that, it's almost pretty much assumed that that is going to be a pancreatic cancer that needs to be removed. What the CA19-9 can be useful for is a number of things. One is that assuming, if you can get the biliary system drained so that everything's flowing, then at least you get more of a accurate CA19-9 level. And the level can be very important because I'm not going to get too much into it just because it's all in the weeds of pancreas cancer, but there is a move to doing things more like preoperative therapy before surgery. So things like chemotherapy and radiation. And one of the main reasons to do that is because, and we'll get to that, but one of the main reasons to do it is because if you worry that a patient has metastatic disease, you don't want to be putting them through a Whipple, right? Because it's a huge surgery, they have a long road to recovery, and if they have a high risk of metastases, why put them through a big, a big morbid procedure? So CA19-9 can be very helpful for you because if it's wildly elevated, if it's in the hundreds or even thousands, it tells you that there's some major trouble that's brewing. And it should hopefully dampen the enthusiasm of any surgeon who wants to take the patient to surgery to say maybe pump the brakes and let's maybe consider trying some chemotherapy or things like that. Where the CA19-9 can also be helpful is if you don't exactly know what's going on, if there's no tumor, if there's no visible tumor, or if there's some diagnostic quandary where you don't really know what's happening, a CA19-9 could help distinguish things. So sometimes, like if you get a node and an unknown primary, then a CA19-9 can kind of help point you in the direction of where you might want to start looking. CA19-9s can be elevated from pancreas tumors. It can be elevated from tumors in the biliary tract. So they can often help you in that sense too. But do you need an elevated CA19-9 to make a diagnosis of pancreas cancer? The answer is not at all. Does that help answer your question?
Yeah, thanks so much.
Sure.
All
So
right. I have a question about that too.
please.
So then let's say you had a CA19-9. Basically my question is, can you use CA19-9 sort of in the way we use PSA to see if a patient has a recurrence?
And so the answer to that question is yes, sometimes. PSA is by far like the most sensitive and accurate, biomarker, tumor marker that we have such that we can pretty much base diagnostic and therapeutic decisions on them. I mean, Everett, I'm not sure if you know, I'm not aware of any other tumor marker, any other cancer site that drives decision-making to that extent. CA19-9 is very useful when it's useful, but it is not always useful. There is a subset of patients that don't secrete, that are considered non-secretors that don't have CA19-9 levels. And, again, the CA19-9 can also be very, it can be very unreliable. So like, whereas a PSA after like a prostatectomy, you should have basically undetectable, essentially 0 PSA. Like all of our CA19-9s are probably somewhere between 5 to 40, and that's a normal thing. So it bounces quite normal. So if it went from 20 to 25, none of us would think twice about it. We would just ignore it, right? But who knows how to judge whether there's something happening right now. It's a very noisy test, so it's not to the level that a PSA can be used to drive decision making. When it's very elevated, I mean, Everett and I just saw a patient yesterday where we watched a CA19-9 go from a couple hundred up to the thousands and now up into the 10,000s. But there was no clear imaging, recurrence. We kept getting scans and we couldn't see any clear recurrence. But, when you see levels like that, something is wrong. And we ultimately got a very short interval scan when the CA19-9 jumped to 11,000. And lo and behold, we finally saw some evidence of some cancer recurrence. So it can be helpful at times, but it is not to the level of PSA. Okay. Okay, so to this, making sure we're good on time here. So there's a T&M staging system for it, which I will argue is not really that helpful. There's really four main categories, the most important categories we care about. I don't care as much if it's T1, T2, T3, but what's most important is it resectable? So that's considered early stage disease. Would it be considered borderline resectable, meaning that it's partially touching the blood vessels, but perhaps we could potentially get it off successfully? There's locally advanced, meaning that the tumor is completely surrounding the celiac or the SMA, and it's never going to come off. And then there's obviously metastatic disease, which is stage 4. And this is a much more practical and useful staging system because this is what really drives decision making. The problem is the vast minority of patients are resectable at the time of diagnosis. So, the common number is, between 15 to 20% of patients present with pancreas cancer with resectable disease, and that's what makes this disease so deadly. Unresectable, of course, would be if you have what we consider, we measure this on cross-sectional imaging, and so if there's more than 180-degree encasement or involvement of the tumor, of the blood vessel by the tumor, then that's considered unresectable, meaning no amount of treatment, chemo or radiation is ever going to get that patient to surgery. And there's some, different systems to help really define what makes something unresectable. And then similarly, if you're less than 180 degrees, so anywhere between 0 to 180 degrees, there is hope for these patients. And, this is where I would say most of the, attention and most of the research is happening right now. Clinical research is really trying to flesh out and define this group because, before, I don't know, like 10 years ago, pretty much you were either put in the resectable bucket, which means you had a chance of cure, or you were put in the unresectable bucket, which means you had no chance of cure. And what we're learning now is that this group, we can actually split up into possibly and never. And so that's where a lot of the interest is happening. And then this is where preoperative therapy is playing a bigger role. And that's what we're trying to show here is that when you have resectable disease, the standard of care is Whipple, followed by adjuvant chemotherapy. And there's various different regimens, but FOLFIRINOX, which is 3 to 4 drug regimen, it's 5-FU with leucovorin, irinotecan, and oxaliplatin. That's now the standard of care. It has more than doubled the survival of pancreas cancer, which is something we learned just a couple of years ago. So this was considered a home run chemotherapy regimen when it came out. Then you have unresectable disease, which this part is very controversial, and we're not going to get into the controversies here because there's too much to talk about. But the standard of care, generally speaking, if you cannot resect it, is to do chemotherapy. Now, where radiation plays an important role is that it could potentially help patients who are borderline resectable. If you can sterilize the vascular margin, the blood vessel margin, you could get these patients to surgery. Similarly, if you have unresectable disease, some people might say the standard of care is just chemotherapy only, no need for radiation. However, there are other data you can use to support, coming in with radiation therapy, because radiation therapy, it's a local therapy, meaning that's meant to treat the main primary tumor itself. And you can imagine, you've got this big ugly tumor in the middle of your belly. Why would you not want to treat that with some treatment, specifically focused on that? And that's the heart of the big controversy, which we're not going to get into. But just to know that radiation therapy can play a role both in the definitive setting for unresectable disease, as well as in the borderline resectable disease to get these patients to surgery. I will say here, there could be a dotted line to possibly using post-operative radiotherapy, which also in and of itself was a very controversial topic. But, that is still probably very controversial. We'll talk about hepatocellular carcinoma next. Just know the liver is not just the liver, it has different segments, and we talk about them quite often when we're describing, the anatomy. That doesn't have too much of a role as far as radiation goes, but just know, again, similar to like gastric cancer, HCC is not as big of a deal in the US as it is in other countries, particularly in Asia, where hepatitis is very endemic. There are various risk factors. Basically, anything that causes cirrhosis is a risk factor for HCC. So hepatitis, alcoholic cirrhosis, things like hemochromatosis, Wilson's disease, this should hopefully ring a bell from your preclinical years. There is also something called NASH, which is non-alcoholic steatohepatitis. Most of the time it's diagnosed with local disease, so liver-directed therapy plays a very, very important role, oftentimes with surgery or with interventional procedures like radiofrequency ablation, and as we're trying to also push radiotherapy. I mean, that really, I don't really want to say too much about this really, other than just HCC, the diagnosis is usually done through imaging. So what you'll see is when you see, and so if you're on like a radiology rotation or you're on something out there, you can impress hopefully your residents, your interns with this little nugget here. But if you see the hallmark diagnostic feature of hepatocellular carcinoma, which is the most common primary liver cancer, is it has an arterial blush and then a venous or a delayed phase washout. So what that means is that on the arterial phase, and you know this is arterial phase because if you look at the aorta, you see how it's very bright white. So that means that it's a very early CT scan phase. And what you see here is you see a tumor that actually looks bright relative to the background liver. So it's enhancing, that's the blush, because it gets a very early influx of the contrast. But then what happens over time is you let the contrast phase out. So you can see now the aortas become a little bit lighter, and you can see the veins now start to actually brighten up. So that's the portovenous phase. And look what's happened to the tumor. The tumor's actually become dark relative to the background liver because the liver is now taking up the contrast, whereas the tumor washed out the contrast very quickly. So if you see a combination of these two features, you have to have both. You can't have one without the other. You have to have both. If you see those two features, then it's an HCC, and that's diagnostic. And you do not need a biopsy. You can actually proceed directly to therapy once you see this feature. So if you learn one thing in this lecture, remember that. Essentially, we don't pay too much attention again to the T stage or end stage because it really comes down to, is the tumor resectable or not? If it's resectable, you resect it. If it's not resectable, then we think about other options, things like, you know, chemoembolization, radiofrequency ablation, other types of things. And so this is just a quick diagram of how we handle it. I'm not going to get too much into it other than just know surgery for early stage. You can also do liver transplant. We have a very active transplant program here. If it's inoperable, lots of different options out there, including, you know, different types of ablative techniques, chemoembolization. You can do internal radiation where you inject radioactive beads into the tumor. And you can also do external beam radiation, which is what we do. And then if you're metastatic, of course, you would probably do more things related to systemic chemotherapy. And this is a much bigger box these days than when this was put together. There's more than just sorafenib these days. Okay, cholangiocarcinoma. This is the bile duct cancers, relatively rare, but still a fairly deadly cancer. Risk factors, you know, PSC is the most common one, primary sclerosing cholangitis, but liver flukes, which I've never seen, but you know, that is a classic risk factor that's put out there. Oftentimes these patients will present with jaundice. These tumors do often, they do like to be aggressive either locally or with distant spread. Patients will often present with biliary dilation and jaundice. So you can see this is an image of a patient with very dilated bile ducts. Often, I'm not totally sure exactly what's happening in this image here, but if you were to scroll down in a classic case, you'll probably see a mass usually right at the porta hepatis. So right at the, where the common bile duct is, which is where, you know, extrahepatic cholangiocarcinomas present. So you see all the bile ducts kind of be dilated and dilated, and they eventually pinch and disappear right at the center where the tumor usually is seen. And that often can be the only indication that you see a tumor because they can be notoriously difficult to visualize. So diagnosing them can actually be quite challenging. You try your best, you try to do an ERCP, go in and try to place a stent to decompress. And while you're in there, you try to do brushings. So you do these brush biopsies where you kind of scrape it with these little brushes and hopefully you get some cells come off, and then you try to look at it under the microscope. And if it shows cancer, then that's great. Then you don't have to wonder what's going on. But if you don't get cancer, which often is what happens, you're left trying to figure out what to do because you know it's a cancer, you know, it smells like a cancer, looks like a cancer, walks like a cancer, but you can't prove it's cancer. And that's where it becomes challenging. And you might ask the question, well, why don't you just stick a needle in it from, you know, from here, stick a needle through and try to get to it. And the problem with that is these tumors are also very notorious for seeding. So if you stick a needle in and then you hit the tumor and then you exit, these tumors are very notorious for actually tracking along the needle path. And then you wind up having a tumor grow basically right at the puncture site of the needle. So we really try to avoid that as much as possible. And that's such an important criteria that some people who do transplants for cholangiocarcinomas will actually, if you were to do what's called a percutaneous biopsy, where you do an external biopsy like that, the patients actually are no longer eligible for a transplant because of that risk. So that tells you kind of how serious that is. But hopefully if you can make the diagnosis, you get your standard imaging. PET scans actually are helpful for this case, but you could get multiphasic imaging with CT or MRI. Here's the T stage and N stage. You can memorize that on your own. And as far as how we manage them, it's kind of like pancreas cancer. If you can resect it, you resect it, and you might give adjuvant therapy. This is controversial about what you actually give in the adjuvant setting. I'm not going to say too much about it, but it's usually either chemo or it's a combination of chemo and chemoradiation. If you're metastatic, you get chemotherapy. And if you're unresectable, we usually will use a combination of chemotherapy with some sort of definitive radiation technique, which could either be long course fractionated radiation or you could do stereotactic radiation. So radiation does play a role kind of in all of these different settings. So moving to what we now call the lower GI tract, which is anything, colorectal or anal. Rectal is probably the biggest topic in GI cancer. There's a ton of literature on this. It's a rapidly evolving field. I'm not going to say too much about it. You could devote several seminars and lectures on rectal cancer alone. But just know that the rectum is the bottom part of the colon. We use radiation for rectal cancer, but we don't use radiation for colon cancer, even though they're biologically thought to be, relatively similar. But the reason why is because the pattern of spread is different based on the anatomy. The rectum sits underneath the peritoneal reflection, so it's not surrounded by a peritoneum. So it has no barrier to spread beyond when it breaks through the wall of a rectum. So in this deep pelvic area where it's very challenging to get wide surgical margins, you are left, you have to worry about margins, whether the tumor were to grow and get close to bones or get close to other structures, and a lot of lymph nodes in the area that if you're left behind can come back and become cancer. And the reason why that's important is because, and I said this to Everett just, I think earlier this week or last week, but if you've ever met a patient who's had an uncontrolled pelvic tumor from a recurrence, it is probably the worst possible way to die that you can die. Oftentimes these patients will have a localized recurrence in the pelvis, but without metastatic disease. And that may sound good to you, but in a way, it would be more merciful if they were to die from uncontrolled metastatic disease, because otherwise they're going to be having many, many years potentially of a tumor that is growing uncontrolled into a lot of nerves that run through your pelvis and a lot of bones and other things. And if it starts to invade, their pain and their misery can be very, can be probably some of the worst that you'll see. And so we do everything we possibly can to try to prevent recurrences as much as possible. And the good thing is that we're very, very successful at that. But that's where radiation plays an important role in preventing those types of local recurrences as much as possible. Colorectal cancers in general are very, what is it now? It's like the third most common cancer, 135,000, of which about 40,000 of them are rectal cancers. Overall, I mentioned to you about 53,000 deaths per year. So overall, fairly curable. Lots of risk factors, a lot of stuff out there, a lot of interesting and exciting genetics that we're learning about that can help with targeted therapies. We're not going to say too much about this. Colon cancer screening is probably the most important thing you can do with screening colonoscopies. Presentation usually is rectal bleeding is the most common kind. So if you ever get rectal bleeding or know anyone, a family member with rectal bleeding, make sure they get their colonoscopies. TN and M staging, very similar as far as the thickness through the muscularis or through the colon or the rectal wall. The number of lymph nodes is important, as well as the metastatic sites. So they actually subcategorize the M stage, the metastatic stage, to either one organ site or multiple organ sites. Okay, so, gosh, walking through this. Rectal cancer has changed quite a bit even over the last 10 years on how we manage it. I don't know how much I want to confuse you with walking through this complex thing, but essentially it's a surgical disease. So if you have very early stage disease, you would try to resect it. You can either do a big surgery, which is called a an LAR or a low anterior resection or a total, an abdominal perineal resection. If you have a T1 to T2 disease, you can manage that with an LAR or APR, and those are subcategorized as what's called total mesorectal excisions, which just means a very radical cancer surgery. And hopefully that's all they need. But where we mostly focus our time and spend most of our time is for those who are locally advanced, patients with nodal disease, patients with T3 or T4 disease. And where things have evolved quite rapidly for these patients is, the standard of care has always been preoperative chemoradiation, followed by total mesorectal excision, and then you might give adjuvant chemotherapy, which is FOLFOX chemotherapy. Now, lots of things have been changing, and I'd say right now the new fad or the trend is to do what's called total neoadjuvant therapy, where you actually would do, instead of doing the FOLFOX chemotherapy here, you move it up front, either before or after the surgery, but still before or after the radiation, but before the surgery. So either chemo followed by radiation and then surgery, or radiation followed by chemotherapy and then surgery. So that is kind of the treatment du jour these days. And then for metastatic disease, because colon cancer, we have such effective systemic treatments, there's this whole, world of what we call oligometastatic patients with colon cancer, which means oligo means few metastatic sites. So a patient with like 1, 2, or 3 metastases in the lung or the liver is a lot different than somebody who has 50 metastases. And so patients who have very few or limited number of metastases can actually have fairly good survivals with a combination of chemotherapy, with aggressive surgery, and even with aggressive radiation. And so even these patients could be managed with curative intent. And we don't necessarily throw in the towel just because they have, evidence of metastatic disease. And then the other big thing that's moving on is that there's also another body of literature that says that you potentially could bypass and not do a surgery and just go straight to what's called observation after preoperative therapy if a patient has a very, very good response to the tumor. So if you treat a patient with chemoradiation and chemotherapy and then you look inside the rectum and the tumor's gone, and that will happen anywhere between a quarter to half the patients. If the tumor is gone completely, and a patient otherwise would need to have an APR, which means that they're going to have a colostomy bag for the rest of their life. I can tell you many patients do not want to have an APR if they can help it. And so where an important, area of research right now is, could you manage these patients with just observation and just very close surveillance and spare them the need of a bag? And I can tell you, patients are very, very motivated for this type of treatment. And there's actually a very fast accumulating mountain of evidence that shows that this actually can be done very safely. So we're actually very excited about kind of this, because one is it puts radiation kind of front and center as a way to cure these patients and prevent them from needing a bag, which many of them are going to be very, very grateful for. And then finally, anal cancer. That's the very, very bottom part of the GI tract. It's the part that's probably within the first, or the bottom like 3 to 5 centimeters from what we call the anal verge, which is right at this point where you transition from the hair-bearing skin to the non-hair-bearing skin. You should recognize this from your anatomy textbooks. So where it sits has different implications on sort of lymph node drainage and things like that. But what's important for you to understand is that radiation in this case actually does play the front and center role for these patients. Because as you can imagine, there is no surgery you can do for anal cancer that would leave them with a functional anus. So chemo radiation as the curative treatment is the standard of care and has been the standard of care now for, going on 4 decades. What's nice about it is that anal cancers tend to be squamous cell carcinomas. In fact, the vast, vast majority of them are squamous cell carcinomas. And as we established from before, a common theme that you'll come across is that squamous cell carcinomas are very effectively treated with radiation or chemotherapy radiation alone. So fortunately, outcomes are very good with chemotherapy and radiation, just in terms of cure rates. But at the same time, you're also sparing these patients from needing to have a colostomy bag for the rest of their life, which again, they're very, very happy to hear. It's a very rare cancer overall, less than 10,000 a year and very few deaths. So that tells you how curable these cancers are. A lot of common and sort of intuitive risk factors you would think about as far as sexual practices, HIV, exposure to HPV, smoking has been listed as one. I guess there are these poor prognosis issues which have been published, I agree, but that's probably not that important for this particular lecture. Common presentations are going to be things like bleeding, pain, rectal urgency. Sometimes they'll just, they may think they have hemorrhoids, and it turns out there's actually a mass down there. Very easy to work up because you can actually visualize and palpate the tumor. So you would certainly do, the physical exam is very important here. You would biopsy it, you would get scans, look at the chest, look at the abdomen and pelvis to look for metastases. Staging is important. So this, as opposed to the other GI sites, staging here is primarily based on the size of the tumor. And the staging, sorry, this end staging is a little bit out of date. So this is an older staging system, but the lymph nodes have a separate staging system as well. But just know that primarily chemoradiation is the standard of care for pretty much all stages. And if you're super early stage and you can manage it with a local excision, you can try, although I don't know if I would suggest that. Anal margin is, don't worry about that. That just means skin cancer outside of the anus, but those are managed surgically because they're managed like a skin cancer. But if you have an early stage anal cancer, this is controversial. Some people might argue you can do surgery alone. I don't really agree with that. I think you should just do chemotherapy and radiation, or at least radiation therapy. If you have anything else, you would treat these patients with chemotherapy and radiation alone. If you have metastatic disease, you can try chemotherapy, but chemotherapy and radiation, I think, would still potentially play an important role for these. So this is a very well-established paradigm that's been around for the last, again, like 4 decades. So this is not controversial, I would say. I think that's it. So that kind of gives you an overview of how GI cancers are managed. Hopefully you can see an important role that radiation plays, or at least where it kind of fits into some of these treatment paradigms. I'm not getting into anything about technique or stuff like that, because I think you probably got some of that from the orientation lectures, or intro lectures on what radiation therapy is. You'll see some of that through our chart rounds. And hopefully I'll get a chance to work with some of you in the clinic, and you might be able to see some of these patients. So with that, Everett, do you have any questions that are coming through the board, or does anyone want to ask any live questions?
I think everyone has just been asking live questions, but speak up if you have any thoughts or questions.
I remember, when I was doing my surgery rotation, like I worked a lot with colorectal surgeons and those who did Whipple, but I remember like there was never any mention of like how radiation therapy plays in it, how even at the time chemotherapy plays a role in it. So, it's kind of, we always think of these as kind of primarily surgical diseases, but hopefully you get a sense that radiation really plays an important role in either curing cancers or at least helping to sterilize disease. I didn't mention in rectal cancer, but the main purpose of the radiation before surgery is mainly because if you were to just take the tumor out with surgery, there's a pretty high chance that you're going to leave behind cancer cells, which then eventually will grow and become pelvic recurrences. And if that were to happen, it would be too late. So you have to give the sterilization of with the radiation along with the surgery, and it works actually best before the surgery. It works better before surgery than after surgery. And so that's how kind of we got to that point. So hopefully you'll see some of that as you progress through the rotation.